Alcohol addiction. Disulfiram, Antabuse. Facts. 1951, approved by the FDA for alcohol addiction. It interferes with the metabolism of alcohol. It blocks the second step in the metabolism of alcohol when you drink. Because it's blocked, you build up a toxic product in your blood. If you drink alcohol while you're taking Antabuse, it makes you sick. Very unpleasant symptoms. Nausea, vomiting, sweating, flushed skin, throbbing headache, breathing difficulties, blurred vision, confusion. So if I'm taking, back up to this one, if I'm taking Antabuse and I drink, and if I drink and I'm going to get sick as a dog every time I drink on Antabuse, maybe I shouldn't drink. So again, it discourages people from drinking. But unlike other anti-addiction meds, it only acts as a deterrent. It doesn't heal any of the damage. And also, it doesn't work if it's still in the pill bottle. So you gotta take it. If somebody's got, I got this, my good buddy's coming into town. I haven't seen him in 5 years. He was my old drinking buddy. I'll hold off for a while because I'm going to party this weekend. Yeah, so it doesn't work if it's still in the pill bottle. I think I've written one prescription for Antabuse, and that's somebody who absolutely insisted, and he said he did well with it. Most folks nowadays, if you do Antabuse, it usually needs to be observed, administered under observation. Naltrexone, Vivitrol for alcohol. Review, remember 51 we had Antabuse, 94 we started using oral naltrexone for alcohol dependence, 2006 we got the shot. Naltrexone can be taken by mouth as a 1 to 3 times a day pill. As with Antabuse, oral naltrexone, it doesn't work if the pills are still in the bottle. So I got people doing oral naltrexone. They got a big weekend coming up, they stopped taking it for a couple days. Extended release Vivitrol, once a month shot again. Full antagonist blocks the opioid receptors. What do opioid receptors have to do with alcohol? I thought it was for opioid addiction. Well, when you drink alcohol, you are releasing and interacting with different neurotransmitters and different kinds of receptors. One of the things that happens when you drink alcohol is you cause a release of endorphins. Endorphins are our body's internal opioids. Those endorphins go to the opioid receptor, same place that heroin goes to. When that endorphin goes to the opioid receptor, dopamine, feel good. By blocking that receptor, by the Vivitrol, by blocking the receptor, it decreases cravings. So, by blocking the receptors, cravings are decreased. Because cravings are decreased, it's less likely you're going to take the first drink. If you take the first drink, and there's a lot of people who like to road test it after they get their first shot, right? If you take the first drink while you're on naltrexone, you don't get the same buzz because the receptor's blocked. So if you don't get the same buzz, you're less likely to take the second or third. Just as with buprenorphine before, I told you that there's a risk with people trying to override the buprenorphine by taking more and more. There's a risk here. You're on Vivitrol or naltrexone, you're not getting the buzz, and people will try to override it and drink over it. And the other problem sometimes for folks is, okay, I'm on Vivitrol, I've taken a drink, oh, nothing. I've taken another one, no buzz. Oh, I'm fine. I can keep drinking with my buddies because I'm doing okay. I can drink that much more. Naltrexone does not block the cerebellum. The cerebellum is where we have reaction time, coordination, things like that. So you can feel okay, get in your car, and be pulled over and blow big and be very impaired, but not feel as impaired. Vivitrol gives a more constant blood level at a lower total dose. When you take oral naltrexone, you get a blood level and it goes away. Take the next naltrexone, you get a blood level and it goes away. With Vivitrol, you get a peak at about day 2 or 3, and then it levels out and stays steady state for the next 4 weeks. Tails off, and then you get your next Vivitrol injection in 4 weeks. So there's more of a steady state, more of constant levels of naltrexone in the bloodstream with the injection. And if you're taking one naltrexone tablet, that's 50 milligrams. That's the standard tablet. 50 milligrams for 30 days, that's a 1-month supply. You're taking 1,500 milligrams of naltrexone. If you're taking 2 tablets of 50 milligrams a day, that's 100 milligrams a day for 30 days, is 3,000 milligrams a month. Vivitrol is 380 milligrams that lasts a month. So you're getting a more prolonged effect, steady state, at a significantly lower dose. So it sounds very good. Most patients stay on Vivitrol for at least a year. Get it? A year. Cost can be a limiting factor for Vivitrol. It can cost anywhere from $1,200 to $1,600 cash if you have no insurance, except the company knocks $500 off of that. So if it, at $1,200, which is the lowest that I've heard, it's about 800, 700, 800. I subtracted 5 from 12 if anybody caught me there. $700 to $800 cash a month. For some people, that's just a limiting factor. I have a lot of folks who can't afford Vivitrol. Their insurance doesn't cover it, or they don't have insurance, and they do fine. They do okay on the naltrexone. Of the two, obviously the Vivitrol is preferred, but that can be a limiting factor. Next drug, Acamprosate or Campral. Facts. Widely used in Europe, anti-addiction since the 1980s. FDA, 2004. Same thing. Remember buprenorphine? 82 in Europe, 2003 for us. God bless the FDA. So here's the same kind of spread. We're not exactly sure how Campral works, but it appears to restore this balance between these different neurotransmitters, GABA and glutamate. Well, GABA, it causes you to feel sedated and relaxed. Alcohol stimulates this system. Xanax and benzos stimulate that system. By the way, Xanax and Klonopin and benzodiazepines are in the same pharmacologic family as alcohol. Some people refer to Xanax as freeze-dried alcohol, but they activate these same systems. So GABA is activated, that causes sedation and relaxation. This glutamate system makes you feel energized, and alcohol suppresses that. When the alcohol wears off, these systems rebound. That's why you get irritability, insomnia, concentration problems, memory, mood swings, increased sensitivity to stress. That's the post-acute withdrawal syndrome. Pause, we talked about it last week. Treatment. Consider treatment with Campral if there are significant pause symptoms. When I have somebody with an alcohol problem, I routinely start naltrexone. I do not routinely treat with Campral unless there are significant symptoms of pause. I think I gave this example at another talk. I had a guy, true story, multiple relapses with alcohol. I went to Sierra Tucson one time, and then I relapsed afterwards. How long after you left did you relapse? It was about 3 months. Another time I went to Cottonwood, but then I relapsed. How long after you left Cottonwood did you relapse? About 4 to 5 months. Pause symptoms, post-acute withdrawal syndrome, peaks at 3 to 6 months. I started that guy out on Campral on day 1. We know he has a history of pause. But I don't use Campral unless I see significant pause. Usual dose, 2 Campral tablets, 333 milligrams. Do not ask me. The answer is because. And it's 3 times a day for 2 weeks, and then we change it to twice-a-day dosing. Most people stay on Campral for, pregnant pause, at least a year. Are you getting it? Not addictive, no withdrawal symptoms. Most common side effect is diarrhea. Gabapentin. Frequent, we can fix it. It is not FDA approved to use in alcohol addiction. Facts, there's only 2 FDA approved uses of gabapentin. One is to treat epilepsy, and this post-herpetic neuralgia, that's shingles. Okay, those are the 2 FDA approved indications. There are many legitimate off-label applications. Off-label doesn't mean illegal, doesn't mean backdoor. There's lots of stuff we use off-label. When used in combination with naltrexone to treat alcohol addiction, or even when used alone, gabapentin can help to decrease cravings and drinking behavior. Here's the articles that comes from. When I prescribe gabapentin to somebody, I give them a copy of these articles so they can see it for themselves. It can be effective in treating anxiety and insomnia. I've used gabapentin. I like it. I use gabapentin a lot. I like gabapentin. I've sometimes used gabapentin to treat just anxiety. If you want to do an interesting Google search, Google gabapentin and anxiety. You'll see pages and pages and pages. Without an addiction problem, just using it to treat anxiety. It can also be very effective for insomnia. So if you're using it to treat alcohol, look at this. You're reducing cravings, you're reducing anxiety, you're helping them sleep better, because these are some of the common symptoms that people have when they stop drinking. We think it works by stimulating GABA. Remember, that's the sedating stuff, and reducing glutamate. That's the exciting stuff. Norepinephrine, that's what gets released when you're in withdrawal. And dopamine. Substances. Coke, crack, meth, marijuana. No current FDA-approved medications for any of these things. Coke, crack, methamphetamine. No medication reproducible. They're looking at stuff like Antabuse. Provigil is a stimulant used for usually narcolepsy. Topiramate, Topamax, similar to gabapentin. Baclofen, muscle relaxer. Naltrexone. Cocaine vaccine. This is actually in human studies right now. Fascinating stuff. They're developing a vaccine against cocaine. The idea is you develop antibodies against cocaine. So if I've got the antibodies and now I try to use cocaine, I got cocaine in my system. The body sees the cocaine molecule as an invader, sets off an antibody response. The antibody molecule attaches to the cocaine molecule. You now have a new molecule. It's too large to pass into the brain. If it can't get into the brain, it can't do nothing. No single supporting psychosocial treatment. CBT, cognitive behavioral therapy. Contingency management. This is a voucher-based incentive. Come in every time, if you're being treated for coke or meth, come in every time you give a clean urine, you get a voucher for a bus ticket, for a movie pass, for other stuff. It works. But you got to have the deep pockets to be able to afford it. But again, no consistent reproducible results. Marijuana, again, no medication, consistently. Promising studies, N-acetylcysteine, NAC, can help decrease cravings. I've been using this in selected people. I'm not talking about the person who has a hit or two once or twice a week. I'm talking about the person who is smoking multiple times a day, every single day. Some people say there's no such thing as marijuana addiction. Well, go talk to the people who attend Marijuana Anonymous and get their opinion about it. It's a low incidence. It's about 7%, 7 to 9% incidence, so that's low compared to other substances. But real addiction, withdrawal symptoms, the whole thing. So, but NAC, it's a twice-a-day medication. You can get it at Sprouts. It's over the counter. Can be very effective. Again, my friend gabapentin can help reduce withdrawal symptoms. Different psychosocial treatments, motivation, CBT, again, contingency management. Get the family involved, but nothing consistent. I've used these in combination, by the way. If I've got a real heavy smoker, I will recommend NAC and gabapentin. And I've seen some success with it. Still early. All of these things, you've seen these before. As a review, medical intervention can dramatically increase recovery success rates, but without an attitude adjustment, we ain't going to get better meds. It's a crime to treat these people without offering them medication. World Health Organization, provision of pharmacologic treatment should be a healthcare priority worldwide. These meds are essential medicines for adults. And again, Dr. Volkoff, evidence shows much, much better outcomes when you use medication.